Ladies and gentlemen, it's a great pleasure to be here back in the Garden City once again. We've heard a lot about innovation today, and I will continue the theme by taking you through a top-flight look on innovation in the area of reflux disease. I am mindful that there are many cardiologists here, so I think that there are some aspects of this that are of interest to both cardiologists and gastroenterologists. We heard from Dr. Manjunath that only innovators wind up being leaders. And I do want to recognize that innovation occurs in many aspects of life. And this week we had two examples of innovators who are true leaders. The first came from the country I live in now, which is the United States. And you can see that we had a very innovative way of winning an election, which led to him becoming our future leader. We also had innovation in this country, and I think we have another innovative leader, and we had multiple innovative ideas from ordinary Indians who spent a lot of time innovating how to convert 500 rupee notes into 2,000 rupee notes. So ladies and gentlemen, it's an interesting example of how innovation drives ideas and ideas drive the future. I want to spend the next 20 or 25 minutes talking about reflux disease. And I want to focus this both on India and give you innovations both in the intellectual thinking about reflux disease, in the diagnostic tools we have for the disease, and the innovations that we have in treatment. So we're focusing on innovation in all aspects: intellect, technique, and treatment. When we look at the epidemiology of reflux disease in India, we have conflicting data. We have data from the Indian Society of Gastroenterology, a multi-center study that looked at prevalence and found a prevalence of around 7%, but two large studies, one of them from South India, show a much higher prevalence of around 22%. The truth probably lies somewhere between these two estimates and is very close to the estimates that we have from the Western world, where the prevalence is about 15%. Now, several years ago, we developed a definition and classification of reflux disease that was a multinational effort, and I want to walk you through the top line look at it, and then we're going to break down a couple of aspects and look at innovations in them. Now, GERD, as we know, is a condition which develops when the reflux of gastric content causes troublesome symptoms and/or complications. We have esophageal syndromes, which we're all familiar with, where we have reflux esophagitis, heartburn as a symptom, but we also have the reflux chest pain syndrome shown in the first box. This is a very important entity and of relevance to cardiologists. Recent research has shown us that this is a unique group of patients who actually present only with episodes of severe chest pain, which bring them to the emergency room and often to the cardiac cath lab. These individuals, of course, have negative studies and cause lots of confusion in emergency rooms and emergency room settings. It turns out that these individuals also don't have symptoms of heartburn very often and don't report symptoms of reflux disease, and we think that their episodes of pain are caused by intense spasm of the esophagus caused by an episode of reflux disease, and the actual sensation of pain may be ischemic in origin from the esophageal wall. In the extraesophageal syndromes, we have a very important group of disorders, including cough, laryngitis, and we are going to look at innovations in our thinking in both of these areas. Now, the most important problem facing us in reflux disease is the group of people who fail to respond to proton pump inhibitors or respond only partially. These patients are defined as being refractory or having refractory symptoms of heartburn and regurgitation, and we define refractoriness by failure to respond to twice-daily PPI therapy for a period of treatment of 12 weeks, and we would like patients to have symptoms at least more than 2 times a week for it to be clinically meaningful in terms of quality of life. So most of our innovation is focused on this group of patients because we haven't been successful in treating them with our conventional means. Before we understand this treatment group, we have to understand the pathophysiology of these individuals. And as I walk you through what we do to identify different subgroups, we need to understand the conceptual terms that go behind it. We know that heartburn and regurgitation with findings of erosive esophagitis occur in 60% of the population, and this is a relatively easy group to deal with. The endoscopy is positive, the patient has typical symptoms, and they typically respond to PPIs. 40% of patients with reflux disease have no findings at endoscopy, but if you perform pH studies on them, as we'll see in a few minutes, they have abnormal acid exposure in the esophagus, and this constitutes the group of patients called non-erosive reflux disease. Then we have a group of patients with normal acid exposure in the esophagus who continue to have symptoms, and this is the challenging group of patients who frequently don't respond to treatment. When we examine them and study them further, if we can see an association between their symptoms and reflux episodes on studies that I'll show you in a few minutes, we call these individuals as having a hypersensitive esophagus. And finally, there are patients who have no evidence of any reflux at all, but continue to have symptoms. And this is a very well-defined group now of people with functional disorders. And the approach to these people is not to treat the esophagus, but to treat the nervous system. And we often use techniques and medications that work on the central nervous system using pain modulators rather than treatments of reflux disease. So let's look at this group in more detail and look at potential mechanisms and how we go about identifying patients and treating them. The first concept that we have is that if we look at the multiple mechanisms, science has shown us that we can have residual acid reflux, we can have a concept called weakly acidic reflux, where the acidity is gone, but the reflux state is very weakly acidic and still causes problems. We can have bile reflux, a concept propagated by our surgical colleagues to a significant extent. Then we can have esophageal hypersensitivity, and as we mentioned, psychological comorbidity. Let's look at each of these in turn. Residual acid reflux is present in approximately 16 to 38% of patients on twice daily PPI therapy. They continue to have an abnormal pH study in the esophagus. Potential reasons are lack of adherence with the treatment regimen, timing of medications, that is, the patients do not take the medications before breakfast and dinner, which is the optimal time when they should be taken, but instead take the medications after eating or at bedtime when the efficacy drops by 20%. And there is an individual variation with PPIs, so it's really important to switch patients from one PPI to another, and though we don't understand the mechanism, it's clearly effective in some patients to switch the medications around. A recent concept that's emerged is the concept of the acid pocket. If you look at the CT scan image, and I don't have a pointer here, but if you look at the CT scan image, you can see a cross-section of the stomach, and at the base of the stomach, you can see a radio-opaque meal that the patient has eaten, and floating on that radio-opaque meal, you can see a relatively gray area, and what this is an unbuffered layer of acid. Our original concepts with regard to meals was that food entered the stomach, acid was secreted, everything mixed up, and then the food was partially digested and moved on. It turns out that physics plays a role here, and that the heavier food sediment sits at the bottom of the stomach, and a free-floating layer of acid is present above. This is called the acid pocket. If you look at the radionuclide study shown next to it, you can see the dark areas are the areas where acid is present. It's present at the top of the stomach, it's present in the small hiatus hernia sac, and you can see a coating in the distal esophagus, and this is actually a major cause of symptoms in people who are refractory to PPI therapy after meals. This has led to an interesting innovation where we now treat people who have post-meal symptoms despite PPI therapy with agents such as Gaviscon, which floats on the surface of the stomach, creating a neutral raft, or with antacids that actually neutralize the acid floating at the top of the stomach. So this is a kind of a new innovation that has practical significance. Weakly acidic reflux in patients with symptoms on PPI therapy. In these individuals, heartburn is replaced by regurgitation as the major symptom. The reflux material is no longer acidic or not as acidic and becomes very weakly acidic. And our studies and studies from other groups suggest that it's just the effect of the volume entering the esophagus by stretching the esophagus that causes symptoms, and how high the refluxate reaches in the esophagus may also have some relevance. Bile reflux has been talked about for almost 2 decades, and it's the reflux of bile from the duodenum into the stomach. And we know that the contents of bile have injurious effects on esophageal function, but only 10 to 15% of non-acid or weakly acidic reflux episodes contain bilirubin, and in one study, only 9% of bile reflux episodes were associated with symptoms. So our current thinking is that this is an infrequent cause of refractory symptoms. A growing area of interest is the psychological impact of psychosocial pathology on esophageal symptoms. Patients with poor correlations of symptoms with reflux events have high levels of anxiety and hysteria, and we know that psychological stress increases perception of pain both by central and peripheral mechanisms, and acute stress can reduce the threshold for heartburn when acid is perfused in the esophagus. So these are the important underlying principles. How do we go about identifying and separating patients into these subgroups? The first innovation we had in the field of measuring reflux was the development of wireless pH metry. We followed the cardiologists in terms of non-invasive long-term monitoring, and we now have a device that has a small implanted pH sensor and a wireless transmitter that we attach inside the esophagus, and there are no wires or cables, and it sends signals through the patient's abdominal wall to a little paging device that collects the data. We started out with 48 hours of monitoring, and now the battery life has extended to 96 hours, and the device falls off from the esophagus automatically by itself and is disposable and is lost in the stool. So the patient comes back after 4 days, turns in the little paging device, and we can see everything that happened from a pH standpoint in the esophagus over that period of time. Now, while this was a great innovation, there were a number of problems with this device. Firstly, it is attached at one point in the esophagus, so we only know what's happening at that point, but we don't know what's happening anywhere else in the esophagus. And it's only measuring acid, so all we get is a pH printout, and we can tell when the acid pH drops below. So it became very clear after a short period of time that this was not enough to solve our problems of weakly acidic or non-acidic reflux. The newest innovation then was the development of what is called pH impedance. pH impedance is both a measurement of pH with a pH electrode, rather like the one I showed you, present in the distal part of this catheter. And then there are multiple electrodes shown in white, which run along the stem of this catheter, which measure electrical resistance in the esophagus. When reflux takes place, electrical resistance falls, and an impedance recording is taken. When electrical resistance does not fall, that means air is present in the esophagus, there is really very high resistance, and we can see that on the recordings as I'll show you. Here's a patient with pH impedance recording who has refractory symptoms despite PPI therapy. We see at the top impedance episodes recorded as these red event markers show us that things have come up into the esophagus. When we look at the pH recording shown as this horizontal line, we can see a very large amount of red, which shows us that the pH has dropped below the critical threshold of 4, showing us that not only are there events that are taking place which are acidic in nature, they are rising high up into the esophagus, shown anatomically here, and these events are acid reflux events. So we would treat this patient by changing the PPI, increasing the amount of dosing of the PPI, and if this all failed, we would really consider this patient for surgical intervention for reflux disease, because this is a classic case of reflux disease that is refractory to PPI. Look at this patient. Here the pH study shows no drop into the red zone, which means there's no acid reflux. If you look at this part, this is all blue, which shows us that there's no impedance events taking place. This patient has symptoms, but doesn't have pathological reflux and doesn't really have any abnormalities that are treatable by further intervention. This is the hypersensitive esophagus, where the patient is responding to ordinary stimuli, small events in the esophagus, and these individuals we treat by central modulators. Here we have an example of a patient where the pH again is in the neutral range, but we look at this episode, there are hundreds of reflux episodes taking place. So we have neutralized the acidity of the reflux state, but we haven't solved the mechanical problem of reflux taking place. This is another typical example of a patient who will benefit by adding prokinetic therapy to improve motility and move stuff beyond. And if prokinetic therapy fails, this is another person we would consider for mechanical measures such as surgical or endoscopic intervention for reflux disease, because we can't help this patient by reducing acid anymore. Now, I said I'd talk a little bit about extraesophageal syndromes. I think they're very important in India. They're not very well recognized, so I want to spend a few minutes talking about them. Our understanding came with the innovations that took place in research in the upper respiratory tract. We now recognize that there is a receptor in the upper airways called the transient receptor potential vanilloid receptor, or TRPV1. This receptor exists in the upper airways and is sensitive to both heat and acid. When this receptor is exposed to acid, it causes bronchospasm, it causes coughing, it causes throat irritation, and you can imagine now the connection that we're getting. Nature developed this to get us away when acidic gases were creating problems for our lungs. So when you are exposed to an acidic gas due to pollution or somebody burning rubber tires, it causes this intense sensation that makes you leave the area and therefore protect your lungs. In reflux disease, small amounts of acid can enter the airways. And we know from research that's been done over the years that acid can enter as a liquid, but acid can also enter in the form of an aerosol, which consists of a bolus of gas with tiny droplets of acid, which can penetrate deep into the airways and activate this receptor. It's no surprise, therefore, that when we look at chronic cough, reflux turns out to be the third most common cause of unexplained chronic cough when we eliminate lung diseases. And taken together, postnasal drip, asthma, and reflux disease account for 86% of all unexplained cough patients. We've also had our colleagues in ENT talk to us about reflux disease causing problems in the larynx. It causes vocal cord changes, chronic throat irritation, a sensation of a ball-like sensation in the esophagus. And our ENT colleagues spent a long time describing different changes in the esophagus, which they thought were typical of reflux disease. Shown here are the 4 changes, which we are not going to go into detail, but suffice it to say that one of the innovations of the last few years has been a randomized controlled trial that looked at videostroboscopic studies and showed them to multiple ENT physicians, both from controls and patients with reflux disease. And wouldn't you believe it, that all of these changes have no predictive value at all. The ENT physicians were not able to distinguish between controls and patients with reflux disease. So how, in fact, do we identify these patients? It required an innovative technology, and I'll show you that on the next slide. So once again, innovation in diagnostics has occurred with a very tiny catheter that can go through the nose, again connected to a wireless transmitter. But this sensor is unique because it can measure aerosolized acid. So in laboratory experiments, we have vaporized acid and place the sensor above the vapor, and it can actually detect acidic vapor. It can detect aerosols or droplets of acid, and this has become a very important tool in our laboratory to identify patients with these laryngeal disorders who have extraesophageal reflux. Here are 2 examples. In purple, you see a patient with day and night reflux, and you can see hundreds of episodes where the pH drops below the threshold of 4 or 6 in this case. And this patient had chronic cough throughout the day due to reflux disease, and after treatment of reflux disease for several months, the cough completely disappeared. Here, on the other hand, you have a patient with nocturnal cough, and you can see the green that the pH is normal during the daytime, but at night the pH drops into the acidic zone and stays in the acidic zone because the patient doesn't swallow anymore and the acid just sits in the back of the throat for prolonged periods. This patient also responded both by changing in diet and by adding acid inhibitors in the evening to block the nocturnal acid trend. As with the esophagus, we've also learned from innovations in the ENT area and in chest area that we have central neurologic mechanisms for cough and laryngeal symptoms as well. And there are three defined areas called laryngeal paresthesia, hypertussia, and allotussia, which are all equivalents of hypersensitive esophagus and the functional symptoms of heartburn, but they correspond to the airways and to the lungs. In the last few minutes, I'm going to spend time on talking about innovations in treatment. We all look for innovations in treatment, and as endoscopists and gastroenterologists, we're now beginning to enter the area of trying to perform fundoplications through the endoscope. So here is one of these devices called transoral incisionless fundoplication, where on the first image you see the device through an endoscope with a clamping device at the end of it, and And what you can see is that we can clamp the top of the stomach and the esophagus together, pass that needle-like device through it, and attach plastic fasteners which create a fundoplication, as you see in the bottom image, where you can have a 270 degree. These patients do this as an outpatient procedure under propofol, and they are able to go home either the same evening or the next day, and they have no incisions. And the current data show that at 5 to 7 years, the results are very good with an intact fundoplication, and the beauty of this technique is that it can be repeated if necessary. Perhaps the most innovative device that has come out in recent years has been the magnetic sphincter. This is a device that we place around the lower esophagus, as shown in the little cartoon. It consists of a ring of magnets encased in titanium. And this uses a physiologic principle. We've known for many years that peristalsis is a high-pressure event where we generate 50 to 80 millimeters of pressure in the esophagus when we swallow, but reflux is a low-pressure event at 5 to 8 millimeters. So these rings close and keep the sphincter closed. When we swallow, the pressure we generate in the esophagus is enough to open the magnets and allow food to pass into the stomach. But when we have a reflux episode, the pressure is too low to open the magnets, and reflux does not take place. This device has been studied now in patients for up to 8 years with very, very good results. Most patients are able to stop PPI therapy. There are very few side effects or complications, and there have been 1 or 2 cases where it had to be removed because the device moved or migrated. The only disadvantage with this device at the moment is its cost, but this was likely to become one of the mainstream devices to be used in the future. Again, following the lead from our cardiology colleagues, we have been looking at stimulators, and we now have a stimulator of the lower esophageal sphincter where we implant electrodes on the lower esophageal sphincter, and we have a device that looks very much like a pacing device where we actually pace the lower esophageal sphincter, applying electrical energy to prevent the transient relaxations of the sphincter that allow acid to escape into the esophagus. Perhaps the area of greatest interest for me personally is this device that we are going to start investigation on next year. This is called a DuraSphere, and you can see in that little bubble tiny spheres of an inert material that we can actually inject through the endoscope into the submucosa of the esophagus, where it creates a wall all the way around the esophagus, reducing gaps in the wall of the esophagus and creating a tightening at the level of the lower esophageal sphincter. Clearly, it's not going to work for everybody, but preliminary results show that it is quite effective, and this device is already approved for use in the urethra and other areas where it's used for urgent continence, and we'll be using it in trials for reflux disease. So in the last 25 minutes, ladies and gentlemen, I've tried to walk you through innovations in our understanding of refractory reflux disease, innovations in recognizing and identifying laryngopharyngeal reflux, and changes in our concept of why people develop symptoms that are refractory to conventional therapy. We have new understanding on functional laryngeal disorders and functional esophageal disorders, and we have new innovations in endoscopic and surgical therapy. Thank you so much for spending your Sunday evening with me, and I think we have time to take some questions. I'm sorry? Yes, the question is, does posture during sleep have anything to do with it? And posture during sleep has a lot to do with it. So let us talk about the science we know. If you eat a large meal, as we tend to do in India, and go to bed very soon after that, then you have a stomach full of acid and food, and you're horizontal, and now if the sphincter relaxes, gravity will force everything up into the esophagus. Similarly, if you always sleep on your right-hand side and empty your fundus down towards the lower esophageal sphincter, you're going to have more trouble with liquid going up. So one of the measures we use in patients is to ask them not to eat or drink anything at all for 2 hours before bed. 3 hours is even better. This allows the stomach to empty. Remember that the gastric emptying time is about 90 minutes for ordinary foods, up to 120 minutes for very fatty foods. So the longer you have an empty stomach, the less likely you are to reflux when you are horizontal. We also know that complications related to reflux disease are all related to nighttime reflux because the acid sits in the esophagus for long periods of time. So patients with Barrett's esophagus and esophageal cancer often have very prolonged nocturnal reflux compared to daytime reflux. So that's a very important question.
Yes, sir. So one more question is, the H. pylori infection induces the coronary artery disease, and the bad dental hygiene induces the coronary artery disease. What's your view, sir?
Well, the question here is H. pylori and its relationship to coronary artery disease. So we've had two sets of studies looking at H. pylori infection and coronary artery disease. We've had serologic studies which associated with coronary artery disease, and we have detection on PCR of H. pylori antigens on atherosclerotic plaque removed from patients with coronary artery disease. There are problems with both sets of studies. Remember that if you just measure serology and link it to coronary artery disease without controlling for all other variables for coronary artery disease, you really have a problem. So there's a huge problem with all those transients, those types of studies. There's also a problem with the PCR studies. The amount of material that you get from the plaque is so small that you have to amplify the signal, and when you amplify the signal, you get a lot of errors. So there's a lot of controversy about this, but I think we can accept. We know from the cardiology literature that pro-inflammatory conditions like rheumatoid arthritis are associated with a higher incidence of coronary artery disease. So it is intuitive that if you have a pro-inflammatory situation in your stomach, it can't be good for you. So I would say that our conclusion is we're not completely concluded that it is related with it, but it is intuitive that it's probably not a good thing to have from a coronary standpoint as well.
Actually, inflammatory theory it was making some news for, infection theory was making some news then.
Yeah.
There was no
That's gone away.
Yeah,
It's gone away from the GI world as well. I mean, we had a lot of interest in this. I did one of those serologic studies back to 15, 20 years ago, but there's a real problem conceptually to link the two. So, we've linked it with gallbladder disease, we've linked it with coronary artery disease, we've linked it with various things.
There was one study giving erythromycin and looked at the control and all.
It didn't work out. It didn't work out.
Good evening, sir.
You are talking about the innovations. You are talking about the innovations in GERD. Just wanted to know the role of ARMS, anti-reflux mucosal surgery.
Yes, this is a technique where there's a mucosal resective technique propagated from Japan by Inoue. I don't have any personal experience with this, and the amount of information we have is very limited. I would advise caution, though, for two reasons. Reflux disease in Japan is extremely mild, and so very small techniques that cause scarring or narrowing in the lower end of the esophagus are likely to be effective. They're on the very mild end of the spectrum. Whereas both in India and in Western countries, in India at least you're in the middle of the spectrum, and as H. pylori disappears, I think you will become to the severe end of the spectrum. I'm not convinced that this technique will be effective in patients with more significant disease. I think we need to wait till we have other populations studied.
So we see that after discontinuation of PPIs,
Yes.
there is rebound hypergastrinemia because of sudden discontinuation. So before we stop completely PPIs, would you recommend a gradual discontinuation or replace with the H2 blocker?
Yes, this is an important question. I'll just fill you in on the background in 10 seconds. There have been studies that have shown that when you stop a PPI and measure acid in the stomach, when you release when you release inhibition, the hypergastrinemia that's present in the stomach drives increased acid production until the gastrin levels fall. So there are studies that show this. There's some doubt about clinically whether it causes symptoms or not, but you can definitely show it on pH studies inside the stomach. It's very simple to deal with this problem. What I do is when I'm stopping the medication, I go to alternate day therapy for 2 weeks. So as a result, what happens is the PPI inhibits, and then you have a day when it doesn't inhibit, and you inhibit. So it actually brings the acid secretion down much more slowly. You can use H2 blockers as well, but I just like going to alternate day therapy and then gradually bringing it down, and it's very effective if you do it that way.
What are the indications of surgery in reflux disease, and what is the percentage you refer to the surgeons?
Surgery still has an important role in reflux disease, but the number of surgical procedures being performed for reflux disease in the United States has been dropping since the year 2009. And it is unclear why it's dropping. There is some increase in bariatric surgery for reflux disease in those who are morbidly obese, and that accounts for part of it. So here are the indications for surgery and who I refer. Patients with large mechanical problems like a large hiatus hernia or a significant hiatus hernia, these patients do not do well with medical therapy. We try medical therapy, but if they're still symptomatic, we need an anatomic correction. Number two, patients who are treated with anti-reflux therapy and are doing well with regard to heartburn, but we are not able to fix their regurgitation. These patients have a typical history. When I bend down to tie my shoelace, half of my lunch comes up in my mouth. But I don't have heartburn, I don't have any other problem. Or after I eat, I have free flow of fluid and liquid back into my mouth, but no heartburn. That's another patient that's a candidate for surgical therapy. We are very selective about patients who are non-responders to PPI therapy. I already showed you the data that these people may be true non-responders, they may have acid reflux, they may not have reflux at all. And one caveat, an important caveat is, if you take the hypersensitive patient or the functional heartburn patient and you perform surgery on them, those patients are the surgical nightmares. Those are the patients who get dysphagia and they never get better. They report bloating and they call you every day saying they can't get rid of the bloating and the gas and so on. So one important thing is understand the physiology of the patient that you're sending for surgery if you want to avoid these disasters and unhappy patients.
Excuse me, sir. We hear these people taking for years PPI. With small doses, response is excellent. Is it safe to continue for years like this?
Yes, we understand that everything in life has side effects, and we always have to weigh the risks and benefits against each other. So I never tell people that we should randomly just take medications forever. But we have very good data now to show us that the complications of reflux disease are related to the presence and the time acid is present in the esophagus. We now have 4, albeit poorly controlled, long-term studies that show us that PPIs prevent the development of dysplasia and cancer in Barrett's esophagus. We have data that shows that stricture disease has gone down in the United States and Western countries since PPI therapy became available. So we have ample evidence. So I have 2 caveats to tell you. Make sure the patient has reflux disease and that you're not treating symptoms for no good reason. And number 2, do as you just said, reduce the dose to the lowest dose required to maintain the patient symptom-free. The longest patient that I have is the first patient that I treated when I arrived in Wisconsin 25 years ago, is still on reflux medications and is doing fine. So we hardly ever see any side effects or complications. With the billions of prescriptions written with this medication, we would have had an epidemic of kidney disease, dementia, and so on if the incidence was very. So I tell patients, we weigh risk and benefit every day in life. When you drive a car, you weigh the risk and the benefit, and you decide that driving is to your benefit as opposed to walking or taking a horse-drawn carriage. Similarly, we make a decision about whether our quality of life, prevention of complications, and then we can accept a low level of risk because we know that even if risk is present, the risk is very low.
Thank you very much, sir. Now any further questions can be taken during dinner.
Thank you very much.